Hi guys, welcome to day 2 of the Arora AKT 30-day challenge. Hope you're well. Hopefully ready for another question. If you missed yesterday's video, our first question, go to our YouTube channel and you can watch that back. But every single day between now and your AKT exam, we're going to hit you with a quick fire question done in live real time in AKT conditions in terms of the time you get to answer the question, followed by a quick debrief and update in terms of knowledge and in terms of technique issues that you can take away from this particular question. Thank you for all the comments that came in about yesterday's question. Really glad that it helped. Hopefully today's is going to be just as useful. So I'm going to go silent for 57 seconds. Have a think about the question. Please jot down an answer whether you're watching on YouTube, Instagram, Facebook, Twitter, LinkedIn, or anywhere where you're watching it, just so I know how you're getting on and that you're interacting with it okay. And then we'll pause. I'll move into the answer. So I'm going to go silent for 57 seconds. Let's go. That's fine, guys. 57 seconds. So remember, that's the average time that you'll get per question when it comes to AKT, but of course some will take slightly longer than others. So this question is all about Enuresis then, so designed to bring out some knowledge-based things as well as some technique-based things as well. So a mother presents to you with her 5-year-old son. She's concerned about his bedwetting and has done some reading about Enuresis. It's the first time that she's come to see anyone about this problem. Which of the following questions would you reply yes to? So this can get a bit confusing, yes, no. So we talked yesterday about trying to make things simple into almost true or false. So what I do from a technique point of view here is basically change that from which you do reply yes to into true. So which is a true statement. Just makes it much easier for your brain to pick that up as you go down the answer. So the true answer is C. So well done if you got C. Is being male a risk factor? The answer is yes to that. It's about a 2-to-1 split when it comes to Enuresis. So C is the right answer. So well done if you got that. Let's just break the other ones down. Is it called secondary Enuresis if it's been dry for 3 months and then starts wetting the bed again? So sometimes if you're reading that at speed, we talked about this yesterday, you can miss out key words and you can kind of brain match. So you word match. So you think secondary Enuresis starts wetting the bed again. Yes, that's true, but it's the 3 months bit that makes that an incorrect statement. It's 6 months before it's called secondary Enuresis. So that's incorrect. You'd say no to that question. B, should all children have a urine dipstick as part of their assessment? This is a tricky one. I'm sure a couple of you would have put this as the yes statement. Because again, when you think about seeing someone with Enuresis, you do think about doing a urine dipstick. It's quite a normal thing to think about. But the key word here is the word all. And that's really important. We talked yesterday about hard words versus soft words. All is a very hard word. It's 100% word. It's basically saying that every single child that comes with Enuresis must have a urine dipstick. Now, of course, there are certain things that put you more likely to think about urine dipstick if you're ruling out UTI, if it's a new onset. We'll talk about these in a second. But it's not all children, and that hard word should stand out from a technique point of view. C, like we said, is true, 2-to-1 ratio male to female. D, I'm trying to encourage passing urine 2 to 3 times in a day. Is this a good amount? So yes, the first part of the statement is true. I'm trying to encourage passing urine, which you would do with a child, but it's the frequency that's not enough. The guidance in ICKS suggests 4 to 7 times a day we should be encouraging passing urine, including things like before going to sleep, etc. So it's the 2 to 3 that makes that incorrect. But again, you might have read that really quickly. Yes, I need to encourage passing urine, and 2 to 3 seems okay, so it's probably yes. But actually, this is where the knowledge bit takes over. It's 4 to 7 times a day. This is too infrequently And then E, is it true desmopressin can increase sodium levels? So again, you might have learnt about desmopressin and learnt about hyponatremia as a side effect, but unless you read that with clarity, your brain might just read desmopressin, sodium, and start to think about that being a yes. So again, these things can happen not because your knowledge is not there, but it could be because your knowledge is not there. But if your knowledge is there, sometimes we can still lose marks because of technique and reading fast and making word matches like desmopressin and sodium can easily happen. So of course, desmopressin can decrease sodium levels, so that's an incorrect statement. So the only one that you'd say yes to is C. So well done if you got that right. So a few key things to remember when it comes to enuresis then. So it's normal up to the age of 5, but also common up to the age of 10. And there are these types that we mentioned in part A of the question. So you have primary enuresis and secondary enuresis. So secondary enuresis, like we mentioned, is someone who starts to bedwet after a period of 6 months of being dry, whereas primary enuresis is when you haven't had a gap, so you've been bedwetting since the beginning up till the point of presentation. And then primary enuresis is split into two types, those with day symptoms as well as at night, and those without day symptoms. So if you're looking at questions, A, try and work out is it primary or secondary, and are there day symptoms or not. If it tells you, that could influence what you do in terms of management. Could there be a physical cause? Of course, you want to be ruling these things out before reassuring and saying it's all normal. So things like overactive bladder, diabetes, of course, UTI, chronic constipation, neurological disorders, and always in the back of your mind think about child maltreatment as well. So all these things should be in your mind when you get a question on enuresis, looking for little clues in the stem which might tell you there's something else going on. This is important, like we talked about, don't routinely perform urinalysis in children and young people with bedwetting, but you do think about it in certain situations, neurontic, like we mentioned, those with daytime symptoms, thinking about things like UTI, background of other things that you want to think about. But it's the all thing that gets us there. So remember, not in 100% of cases, the guidance is quite clear. We don't routinely do it in all children and young people. And then what if you get questions on management of enuresis? Lots of different stages and steps depending on the stage and the type of enuresis. So reassurance may be appropriate in a number of different questions that you do on enuresis, but make sure you're not missing out these other potentials. Having access to potties, for example, at bed, so changing the way that sleep is arranged, encouraging pre-sleep urination, like we mentioned, and like we said, encourage passing at least 4 to 7 times a day. 2 to 3 is not enough, and that's why that wasn't the answer in this question. Reward systems like star charts, you can get things like enuresis alarms, and then of course desmopressin is the key medication that we think about when it comes to enuresis. A couple of key things to remember when it comes to desmopressin in case it comes in questions: it can be used short term, it can be used long term. Usually it's age 7 and above, can be given orally or sublingually, so different routes for desmopressin. How does it work? Of course, it mimics ADH, antidiuretic hormone, so it's reducing the production of urine and thereby reducing the amount of enuresis, hopefully overnight. The main thing that we mentioned people worry about is hyponatremia. It can cause other things as well, but hyponatremia is the one that stands out, particularly in medical exam questions, and therefore the answer to that is to fluid restrict. So you basically allow sips of drinking from only little sips really, so not drinking glasses and things, very small sips from 1 hour prior to taking the desmopressin medicine up to 8 hours after taking it. So you're reducing the risk of that hyponatremia happening because you're reducing the fluid overload impact. So there's no evidence of adverse effects if used long term. So if you get questions on, can my child take it for X number of months or years, then there's no obvious impact noted from long-term use. And of course, you may have questions where you need to think about referral when it comes to enuresis. There's some guidance on this. So of course, it will be a gut reaction sometimes, and it's not quite fixed in stone, but certain things should make you think about referral more than simple reassurance or primary care management. So things like if they're getting daytime wetting as well as nighttime wetting, secondary enuresis stories, so someone who has been dry, who's now gone back to bedwetting, recurrent UTIs, physical causes, and other things that you may note that take you down the referral route. So enuresis is a very, very common presentation. Things that you need to pick out in questions to make sure you don't miss the referral type of picture or the red flags, for example, but then lots of the things that you might think about from a management point of view, as well as an assessment and diagnosis point of view as well. So worth going through the NICE UKS guidance for enuresis. So again, a couple of knowledge-based things here, but also technique-based things. Remember, try and make questions, frame them as true or false in your mind. It's much easier for your brain to think about that. Look out for hard words versus soft words. These little things can make a big difference. And then watch out for your word matching. Desmond pressing sodium, automatically you're kind of thinking that's right, but the small words can change things there as well. Hopefully we'll see you tomorrow on day 3 or 28 days to go. Just a quick reminder about all the different social media streams that we teach you on, that hopefully you can make full use of in the next 29 days before your AKT. You're probably watching this on one of our streams already. Of course, YouTube is where we post these AKT countdowns, but we also post them on our Facebook group and our Facebook page. So the Dr. Arora page, we have daily teaching there, but we have much more daily teaching in our GP training support group, so you can search that out on Facebook. Instagram, we do loads of image-based teaching and colors and things that tend to stick in your mind that you kind of flick through and just passively learn as you go throughout the day. So have a look at us there at Dr._Aman_Arora, Twitter as well. And we do our alternative AKT countdown teaching on TikTok, our 60-day countdown. We're well into that by now, so you can click onto that and watch those if you learn through those types of videos. But once again, if you're 29 days away and you've done these first 2 questions and you're thinking, okay, this is quite challenging, this is the kind of stuff we're going to work on every single day between now and your exam, so you start to build confidence from a knowledge point of view, but really, really importantly, from a technique point of view as well. Look forward to seeing you tomorrow. If you think of anybody who might find these countdown challenges and questions helpful, please do share the links so other people can get value from them as well. See you tomorrow. Campus will pass.